The Sound of Seizures, developing an audio-triggered seizure detection app. Dr. Basha?
Thank you, Russ, and I really appreciate that survey. That really is a good transition. I'm going to go ahead and share my screen here with you guys in my presentation. Good evening, everyone. My name is Maysaa Basha, and I am an epileptologist at the Detroit Medical Center in partnership with Wayne State University. I'd like to thank Russ and Brianna for bringing me on and for putting together this conference. This is a very important conference for all of us in the epilepsy community, and I appreciate being part of it, as well as everybody else at the Epilepsy Foundation of Michigan. So today I will be talking about the sound of seizures and updating you on what we're doing at our center. So to begin, I'll be discussing the need for seizure detection tools and where they become useful. I will identify how seizure sounds can be detected by machine learning algorithm. And we can describe as well our next steps and how do we incorporate these findings into technology and make it more user-friendly. So why seizure detection? Patients with seizures have increased risk of injuries and death. Injuries can occur during seizures. They can also occur after seizures. During seizures, there's loss of consciousness, there's diffuse shaking of the body, and that in some cases can result in falls if someone is standing, and subsequent injuries. After seizures, there's a slew of hemodynamic and physiologic changes that can result in injury, such as irregular breathing, a low oxygen level, heart rate is affected, and also after seizures, there's ongoing confusion and disorientation, which can get a patient into trouble. They can have difficulty in speaking and moving, making it more difficult to seek help if they are injured. Seizures can also, in rare cases, can lead to death, whether it's through status epilepticus, which is a phenomena that can occur if seizures don't stop spontaneously. This is associated with high morbidity and mortality, and can also occur in SUDEP, which is sudden unexplained death in epilepsy. SUDEP is rare, but can be quite devastating when it occurs because it's unexpected, and although the occurrence, and there's a lot of unknowns with it as well. I think that makes it very devastating when it does occur. Despite the rare occurrences of SUDEP in the epilepsy community. We know a lot, though, about SUDEP. We know that it is likely due to the failure of some spontaneous recovery that normally occurs after generalized tonic-clonic seizures. We also know that the frequency of these specific types of seizures is the most important factor. There are other factors, but this frequency, how often an individual with epilepsy has a specific type of seizure, is associated with SUDEP. We also have, over the past 15 years, identified some protective features. Up until now, we've really had one study. This is back in 2005, published in Neurology. It's a study out of the UK, which looked at risk factors and anything that could be protective. And the one thing they could identify is supervision at night can be protective, whether it's through sharing of bedroom or having listening devices. This was the only thing that was identified that potentially can be protective against SUDEP. For the past 15 years, that was the only thing that we had. And then until recently, actually earlier this year, something similar was able to be replicated. This is a population study out of Sweden that demonstrated that living alone was associated with a 5-time increased risk of SUDEP. So when we put these two factors together, we can see how a seizure detection tool can be useful and can potentially have a role in the protection of seizure patients. When we also send out surveys to stakeholders, people with epilepsy, caregivers, physicians, most caregivers and most physicians find that there is a role for seizure detection devices. The more severe the seizures are, the more likelihood a patient or a caregiver believes that the seizure detection device is useful. The expectation of the accuracy of the seizure devices, though, is pretty high. When surveyed, most folks want detection to be as close to 100% as possible, which is a pretty high mark there to meet. And they tolerate about 1 false alarm per week. When we look at what exists out there in terms of seizure detection products, there is probably anywhere between 30 to 40 devices out there. So I did not want to take the time and go over every single one of them. A lot of them are in production, some of them are research-only devices, and several are available on the market. I've highlighted here 4 different devices, mostly based on the different physiologic response that they used for detection. MFIT and MedPage MP5, these are movement centers. So these devices are positioned near the patient's mattress typically, and can alert the family and the caregiver if a movement occurs, significant movement. You can imagine that there is a lot of false positives associated with those devices, but often can prove to be useful. SAMI uses video recording that is triggered when there's an unusual motion. And these devices have to be confined to a specific environment. They're not mobile or portable. So typically they're placed in a patient's bedroom. Embrace is a wristband. I think this is the most popular one. And it uses multiple types of sensors and different things that feeds into the detection software. The more advanced version of Embrace is the Empatica watch. And what the company learned to do is use machine learning algorithm embedded to help detect seizures with higher accuracy. And this is actually was the first in-kind device, seizure detection device, to be ever approved by the FDA. And this occurred in February of 2018. When we look at Embrace, the sensitivity of seizure detection is anywhere between 89 to 93%, depending on the study that was used. And the false alarm rate is not very high. It's not as high as other devices, but you're still getting about 1 false alarm every 1 to 2 days. For someone with very high seizure load, this can be tolerable. So how do we get to seizure sounds? There's a few things we learned from Embrace, which is multimodal, or more information fed into the system of any device only enhances its accuracy. And we know that seizures have very unique sounds. They start with a very high-pitched ictal cry. There's a tonic jittery phase with a kind of thumping clonic phase that follows. And then at the end, there's an irregular breathing pattern that produces a grunting or a snoring. In fact, before we started this project, we were able to train learners how to recognize tonic-clonic seizures by ear. So we were able to, with very brief prompting, improve the accuracy of identifying tonic-clonic seizure by listening from anywhere from about 55% to 75%. And this triggered us, if you don't mind the pun, to explore it more on a machine learning algorithm basis. And this is, again, what we learned from Embrace is that using deep learning models only enhances your device with partnership with folks and researchers from the College of Engineering. This is what occurs with many audio recognition tools that are familiar to us, such as Google Home or other devices such that would recognize speech and voice. And just like those devices, this can be very challenging because there's high variability. The speaker, or in this case, the patient, has its own attributes, vocal cords, body habitus, which affects the output of the voice, or in this case, seizure. And there's also different styles, or in our case, different seizure types, different durations. Some seizures don't have the ictal cry and only have the tonic-clonic component. And also, seizures occur in everyday life while patients are watching TV, listening to music. So we have to account for environmental noise. And this is where convolutional neuronal networks is it sounds very much like brain because it works. It's a technology that works like the brain. It makes connections and it learns. These types of networks are employed in speech, audio, and facial recognition. And we've been using that to teach the algorithm to learn how to recognize tonic-clonic seizures. So at this point, I had just the idea, and this is me at the Epilepsy Foundation Shark Tank competition. We had the idea of the seizure sound, and we knew we had the engineers to help us develop the CNN needed. And the Epilepsy Foundation invested in us, and we were very thankful that we were able to make the pitch and turn the idea into reality, or into research at this point, and hopefully to reality soon. So what we did was we went back to our epilepsy monitoring unit stationed at Harper Hospital, and we retrospectively reviewed about 1 year's data of seizures and admissions, essentially. And about 180 admissions were reviewed. 49 patients who had 69 tonic-clonic seizures in our unit were reviewed, and the audio was, this is IRB approved, and the audio files were extracted. We excluded some due to poor sound quality. And then we ended up with about 65 events that that underwent audio segmentation, and essentially labeling these segments as either seizure or non-seizure. This was done by an epileptologist, which is me, using the gold standard of video EEG. So I did not rely just on the audio. It was guided by the gold standard of video EEG monitoring. We had about total 15 hours of sound data that was compiled. And then we sent it over to the engineer, Dr. Ming Dong, who was at the Wayne State University College of Engineering, who was able to do, his lab was able to do the data set processing. And what they do is they turn the data into positive samples and then match them to randomly selected non-seizure sound within the same recording. And then this data undergoes sound segmentation and segmented into half-second parts. These are further split into a set that's going to train the algorithm and then a set that's going to test the algorithm. Each segment is converted into a spectrogram, and that feeds into what we call the CNN. And this is, I will not even dare to divulge further into it because I'm still learning more and more about CNNs here. But they are essentially deep learning tools that have been used, as mentioned before, to develop applications that are used for image or video recognition, medical image analysis, natural language processing. So there's a lot of applications that these are used for. The nice thing about these networks is there's very little pre-processing of data is needed. You can just use the raw data that you extract from the epilepsy monitoring unit and feed it into the system, and it will categorize the data in a way where it will be able to part it into more simple patterns. So at the end of it, we had about 25,000 samples that were trained and close to 6,000 samples that were tested. And we ended up with pretty good results. We had precision of close to 92% and a recall close to 91%. Now, these were training sets. This is not real life world, but we have a model and we're ready to move on to the next step. In parallel, we've been developing this deep learning engine in a way where it can be stationed on a cloud. And this was very important and a learning point for me is that things have to be done in parallel. This needs to be compatible on a cloud because ultimately our goal is for our sound to be picked up by a portable device, be recognized on a cloud, and then delivered to the caregiver as an alarm, with the option of the patient giving feedback and saying, nope, this is a false alarm if it was not a seizure. So this could be something that could learn on and be unique to the patient's own seizure, because as we said before, seizures are variable and unique. So what are next steps? We have to improve the accuracy of our data using more data. And we are going, instead of retrospectively collecting this information, we will be prospectively collecting it in the epilepsy monitoring unit to ensure it's clean data with even less processing than what we had to do before. Then the next step, usually in seizure detection, is testing in the EMU, and then testing in the real world is ultimately our final step. So this is where we are. We're in the prospective multimodal testing in the EMU. And again, one of the things that we learned is integrating multiple factors become important. So more is better, essentially. And this is evidence when seizure detection tools are looked at as a whole. When you use multiple variables to feed into the system rather than a single modality, you become more successful. So our part 2 of our study, we're prospectively collecting it using the gold standard of continuous video EEG monitoring to ensure that these are epileptic seizures we're collecting the sound from. We're also integrating continuous pulse ox into the EEG, respiratory function using chest and abdominal belts at the same time. And when you talk to one engineer, they talk to their friends. And so we've made new partnership looking at a Professor Yang Xu, also within the Department of Engineering at Wayne State University, looking at ballistocardiogram. And BCG is the vibration that's generated by the blood circulating during every cardiovascular cycle. So systolic and diastolic, if you can see here. So every one of these is a vibration that's picked up by the heart rate. So we hope by integrating BCG, we can improve our seizure detection by looking at physiological markers as well. And perhaps because the physiologic function is so important to SUDEP, is perhaps also look for diagnostic and biomarker tools in SUDEP at the same time that we're developing the seizure detection software.
Okay, thank you, Dr. Basha.
Thank you.
Excellent presentation. We'll have a little extra time for a Q&A. We finished a little early, so I will remind people to please use the Q&A feature to submit any questions that you have for Dr. Basha. Presentation, I noticed there was somewhere around 30% or about a third of patients said that they often or always had a distinctive sound during their tonic-clonic seizures. So what happens for those who don't reliably have sounds, I guess the question is, do they actually have reliable sounds, but they're just not detectable to the average human ear?
Yes, tonic-clonic seizures have unique sounds. I think it's a matter of whether or not you recognize it. I think caregivers will probably tell you that it's very unique. Are they the same sounds from one person to another? No. And that's where the CNN becomes very important, is that it needs to learn your sound. And just like certain software need to recognize your voice, that would be the same.
Okay, great. So we do have a question. How soon will this possibly be available to pilot with individuals?
We're still a little bit far away. I think the next step is to refine the network. So it's not just spitting out 91 or 92% accuracy using trained data, but actually feeding it the perspective data that we're going to be collecting. So it took us, when I got that check, that was about 3 years ago. We didn't get started until maybe about 6 months to 8 months after that. So I would say it took us about 2 years to get here. I would suspect we have a good algorithm. I would suspect probably 1.5 to 2 years before we can test it.
Okay, great. And how does this relate to the real world life of someone with epilepsy, and will it change or affect treatment?
I think that's a very good question. Will it change or affect treatment? If you notice in that survey that was put out in 2016, it was put out to caregivers and physicians. And 85% of physicians thought this was important, not only for safety. I believe it can provide feedback to the caregiver as to how many tonic-clonic seizures are happening. So it can be also a tracking device. And I know, for example, Empatica right now is used in clinical trials to give sort of that additional accuracy that sometimes we lack as providers.
Okay, great. We're getting some comments as well, so thank you. This is exciting and so important, so that's great to hear. Someone mentioned non-epileptic seizures, and are there devices that might be able to help with psychogenic non-epileptic seizures?
That's very interesting to bring up. This was actually one of the human ear project that we did, was to compare non-epileptic seizure sounds to tonic-clonic sounds, because we do find that sound is very important in the epilepsy monitoring unit to help us make the correct diagnosis. Are we looking at that specifically? No. I think there are other things, other physiologic parameters that may be helpful. But I do feel that the unique sound with tonic-clonic seizure does not occur in PNES.
Okay. What was the age range of the original subjects in your original?
They were all adult patients. I think I failed to mention that. And we had a range between 20 to about 60, I believe. Okay.
And is this technology only going to be available for patients with tonic-clonic seizures? This individual's son does have a sound before some of the seizures, but he suffers from complex partial seizures.
Yes, so this is specifically for tonic-clonic seizure, but when we do our perspective data collection, we're going to be looking at all seizures to see, as you mentioned, there are certain things that are very unique. Often I even hear from patients and patients' family is that sometimes it's a look on a person's face, or maybe just a small grunt or whatnot. Are we able to extend that technology to that level? I'm not sure, just given the environmental factors you have to take into account, but we will be looking at it when we collect the data prospectively.
Okay. And someone asked, how could we volunteer ourselves to help collect any added data? I imagine that really depends on when you're ready to recruit people for that, but is there anything people can do in the meantime?
Yeah, that's a very good question. Right now, we are in the IRB approval phase for the prospective site. We will be recruiting patients only who need an epilepsy monitoring unit admission. So we won't be admitting patients just to provoke seizures, and that would be unethical. So whether or not we would extend it in the future to capturing sounds at home, that's something that we've talked about, but we're not in that process. But that would be a way, if we get to that stage, that perhaps people can submit their audio sounds if they do record it through video or whatnot. And then that will allow us definitely a larger data set.
Great.
Another thing we thought about was collaborating with other centers to also make our data set more robust. So that's, I think once we get a little bit better algorithm, we'll be able to do that as well.
Okay, great. And could this modality be used in conjunction with other devices?
I think multimodal monitoring, and just as that study highlighted, is the more, again, going back to why Empatico was successful, is they've used different inputs. And I think seizure sound on its own is what we're finding is it's not going to stand on its own. Can it be incorporated into other devices, or with the BCG monitoring that we're doing, can those two in combination yield a seizure detection device? That will be our goal.
So this eventually may involve partnering with another company that already has an existing device or something along those lines?
Potentially, yes. Yeah, and in the Epilepsy Foundation, actually, Shark Tank competition, the medical director was also serves as an advisor and has put me in contact in the past with different developers. I think that's what's so nice about this community, is that we're doing this so that we can find answers. You know, our connections haven't panned out just yet, but hopefully in the future we'll be able to develop something for the community.
Great, great. One mother asked, I'm sure our son does have noises, but how do we know what they are? How do we know what they are that would be used under research purposes? I guess to clarify, what is considered noise? Coughing, choking? Are there certain noises that would that have not been studied that are associated with seizures, or that could be added to the ones that you've already studied?
Yeah, I think the pattern itself right now is what we're focusing on. So most patients at the end will have that grunting and a little bit of a choking sound. And that we actually find to be one of the more useful sound. Surprisingly, I think initially we focused a lot of energy on that ictal cry, but a lot of patients don't have the ictal cry. And it turns out that end grunting sound tends to be in most patients. And that's where we're focusing a little bit more on.
Yeah, and I suspect when we did that poll at the beginning, when we asked about a distinctive sound, I would guess that most people were immediately thought of that ictal cry, like you either have or don't.
Yeah.
And you forget that there are all these other sounds that are a little more subtle.
Yes.
So, So another question, this project seems only to focus on sounds. Has it been considered to add in movements detected by a smartwatch along with the sound to help detect seizures and potentially prevent false positives? I think we kind of answered that question, that ideally this will be a multimodal system, right?
Yes.
Okay, great. And would this potentially be, yeah, that looks like a similar question about it being
Great minds think alike.
Yeah, I know. Something that could be added to the Embrace watch again,
Yeah,
or
yeah.
a separate wearable device. So
Yes.
both are a possibility. And then someone's son was diagnosed with absence seizures and is having trouble controlling the seizures. He was diagnosed with an EMG admission, that may be EEG admission, about a year ago, and has been diagnosed 2 years ago. Would he qualify to participate in the study? So would children possibly qualify?
So we're mostly an adult center. So right now we're focusing on adult. We do have our partners at Children's Hospital of Michigan. So depending on how good our results are, obviously we want to extend it out to the pediatric population as well. The absence is probably because it doesn't make a lot of sound, may not fit our study. What becomes of the BCG data is something we can see, and we're hoping that can perhaps reveal more than just tonic-clonic seizures.
Okay, and a couple more questions here. How long until the alarm would be sent from when the sound is detected and it's verified or confirmed to be a seizure or a suspected seizure? How long would the delay be?
That's going to be another big challenge, is how do we incorporate, let's say we have a great device, how can we incorporate it into a smartphone or a tablet? A couple of things that I think is useful and unique is that this doesn't necessarily have to be wearable, so it could be at the bedside and pick up the sound, and the same with the BCG. Even early changes that are recognized can potentially send a signal. So we're modeling it similarly to the Empatica. So it's going to be variable and very patient dependent.
Right. Someone asked about having a VNS integrated with something that would help, something like this that would potentially help to reduce the risk of SUDEP. Is there, that potential for VNS or RNS to integrate with some of the seizure detection and alert device?
Yeah, I mean, VNS definitely is something. I'm not sure if they're looking as a company into seizure detection. I know they definitely rely on the accelerated heart rate for that extra impulse. So they do have some technology there. Are they interested in integrating into additional findings? If we have a good product at some point, perhaps we have to get there first.
Right. And I know we may have some representatives from NeuroPace or LivaNova, so if anyone is able to provide any insight on that, you could certainly use the chat feature to do that. And one other question, why don't all seizures have sounds? So I guess maybe a follow-up to that question would be, are there potentially subtle sounds with other seizure types that could potentially be used in a later version of this device?
Yeah, so the reason to focus on tonic-clonic seizures is really its association with injury and SUDEP. Although a seizure detection software that can be a counter, it becomes very important for management, it's not as essential and it becomes more difficult. So you have to kind of balance the better that you make your device, the more sensitive, potentially the more false positives you get, the more false alarms you may get. So focusing on a seizure type that potentially can have room for immediate intervention. So for example, for tonic-clonic seizures, you can administer rescue medication, you can call for help, you can make sure the patient is not prone, is on its back or on its side if there's saliva. So there are some interventions that can be made even if you're in the next room and you're alerted. And then the detection is really focused on that perspective, not so much as a counter per se.
Right.
I think if we go down the counter, then you're looking more for perhaps VNS on heart rate or RNS actually picking up the seizure rhythms. BCG is something that perhaps can play a role because it's heart rate dependent. But we're very early for me to even comment on something like that.
Great. Okay, well we got just the right amount of questions. Oh, there's one more question. We'll wrap it up on this. How many different types of sounds are there, and what does the sound like? Well, I don't think we'll do any vocalizations of the sound,
yes.
but
okay.
If you could let us know just roughly how many different sound types there are.
So when we look at each seizure, it's every single one of them is unique, but it's repetitive and it's stereotypic to that specific patient. So the patterns are really those three major patterns I talked about: the ictal cry, which is high pitch, the jittery shaking of the muscle, and then followed by like a deep, irregular breathing that can be coarse and audible. So those are the three major sounds and parts. And some patients may have just 2 out of the 3, or just, the grunting end part usually is what we find in most patients.
Okay. All right, perfect timing. So we are going to go ahead and transition to our next presentation. But thank you so much, Dr. Basha, for an excellent presentation.
I appreciate it.
We have a lot of eager people waiting to see this develop. So.
All right, thank you. I appreciate it.
All right, Dr. Hernandez.
All right, great. Thank you. Thank you for having me, and well, thank you for the Epilepsy Foundation of Michigan for doing this conference, especially online, where we can have more participants that might have not been able to come in person. So I'm glad to be here, and welcome to all the participants that are on the call tonight. Next slide. So I will be going over, giving you sort of an overview of the common symptoms of COVID. What is the risk of developing COVID-19 and the risk of complications among people with epilepsy. I also will be talking about the risk of increased seizures as a result of COVID-19. We'll give you some instructions for those people with epilepsy who have symptoms with COVID. How to get medications if you need them, when to go to the emergency room if you have a history of epilepsy and you have COVID-19. And lastly, I'll go over a little bit about mental health. As you know, it's very difficult to be in our homes all this time, but I'll try to go over a few things that you could be doing to help yourself improve your mental health. Next slide. So I wanted to start first with discussing the coronavirus, which is actually the main virus that we're talking about. This is a whole family of viruses that are associated with coronavirus, and for us it's called human coronavirus because we're humans, but coronavirus have been discovered in animals as well, including dogs, cats. We know that can carry coronavirus. We know that the transmission of the coronavirus is via droplets, basically people sneezing or coughing around you. People that are normally breathing around you is unlikely or less likely that you will get this virus. But probably more importantly too is the contact spread. People have reported that there's lifespan of the virus on surfaces could be as long as 3 days. Of course, now that we're getting a little bit warmer in Michigan, we might not see the virus live that long on surfaces, but it is always important to clean the surfaces very well to prevent that contact spread. Of course, washing your hands on a frequent basis is very important. So I wanted to start with the two, just to separate coronavirus into two, the common coronaviruses and then the others, and we'll talk about specifically about COVID-19 moving forward. But coronavirus is a very common virus. In fact, where 90% of us adults have had some sort of exposure to a coronavirus infection, because 90% of adults have antibodies against some sort of human coronavirus. Usually the symptoms starts about 3 to 4 days after your initial contact with the virus. It tends to be more common during the winter time. Children tend to be more affected for the common types of coronaviruses, not for the others that we'll be talking about a little bit later. So some of the common symptoms are very general, like runny nose, sore throat, nasal congestion, sneezing, cough. Some people can have fever, some people may not have fever. Can present as a simple ear infection, croup, pneumonia, or bronchiolitis. So these are the most common types that we are going to see, and guarantee that all of us on this call at some point have been exposed to a coronavirus infection, but perhaps even unknowingly. And then we have the others. These are more severe forms of coronaviruses. The first one that I have listed there is the Middle East Respiratory Syndrome, also called as MERS. MERS was first discovered in Saudi Arabia in 2012. It actually got their way to Europe and other countries, but as quickly as it came, it actually went away. There are a few cases that pop up here and there, but it's not an infection that had lasted that long. The other one is SARS, and there's two different SARS. SARS is this older version of SARS, and then you have SARS-CoV-2, which is the COVID-19 infection that we're going to be talking about. So SARS was first recognized in February of 2003 in the continent of Asia. Again, it's another coronavirus that was causing severe acute respiratory syndrome, very similar to COVID-19. And again, this virus came on in 2003 and it disappeared into 2004, and we haven't had any other cases of SARS since 2004. So if you go to the CDC website right now, the only information you're going to be able to read is about up to 2004, because there haven't been any other epidemics of SARS. Now the new coronavirus that we're dealing with is the SARS-CoV-2, also known as COVID-19. Next slide. And so the symptoms are very similar to what we just talked about for the common coronavirus symptoms, including fever, difficulty breathing, cough, sore throat, body aches, headaches. And this one is a little bit different in that there are some patients that say that they know that they're going to start having the condition because they lost the sense of taste or smell, which is different than the other coronaviruses that are out there currently. Also, people can develop sore throat, congestion, or runny nose. Some people can also have nausea and vomiting. Some people can have diarrhea in association with this condition. All right, so next slide, please. So when to seek emergency medical attention for this condition. So COVID-19 can cause very similar symptoms as I just described, but you should be seeking emergency medical care if you have trouble breathing, you have a lot of pressure in your chest or persistent pain in your chest, you're confused, or you're yourself notice that you're not making sense, or someone next to you feels that you're not making sense when you speak, inability to wake up or to stay awake, people that have their lips turns blue or their fingernails turns blue, or for in our epilepsy population, if you have increased or uncontrolled seizures in association with this virus. When you call 911, try to call ahead and let them know that you're seeking care for someone that may have COVID-19, so the staff or the emergency medical response people know that how to prepare for that call. Next slide, please. So what are the higher risk groups? So we know that adults over age 65 tend to be more at risk. And we also know that very young infants, infants less than 1 year of age, tend to be also a higher risk than the general populations. Residents that live in long-term care facilities are also more affected. And people with chronic medical conditions, whether you have heart disease or lung disease or kidney disease, people undergoing cancer treatment. If you had cancer and you're not undergoing treatment, you're not on this list. Sickle cell disease, if you're taking immunosuppressant medications or you're immunocompromised for any condition. I talked about the very young infants, people with diabetes, severe obesity, and I get a lot of questions regarding pregnancy as well, and there's still very limited data regarding pregnancy and COVID. As you can see on this list, epilepsy is not included. Next slide, please. So epilepsy alone does not increase your risk of contracting COVID-19. It increases and does not increase the severity of your disease. People that have uncontrolled epilepsy may have other medical problems that could place them at higher risk of developing more severe symptoms of COVID-19. For example, patients that have swallowing difficulties or frequently inhale food or liquids when they're eating into their lungs, or at higher risk of developing pneumonias for any other reason. Also, there may be patients with epilepsy may be taking medications for their seizure control that could predispose them to have a more severe case of COVID, specifically patients that are immunotherapies, patients with epilepsy that are taking steroids or IVIG or ACTH medications. So another question that I get frequently is, can COVID-19 increase seizures if a person develops it? And the preliminary information that we have from countries where the outbreak started, the risk of worsening seizures with COVID-19 appears to be low in patients with epilepsy. When a person with epilepsy gets sick with another illness, especially with a fever, you might notice a change in the seizure frequency that might be increased or might not change at all. So you have to look into your history, and if you've had worsening of seizures during fevers, you might be at a higher risk of developing more seizures during a COVID infection. Next slide, please. All right, so what do I do if I develop COVID? So I think the important thing is don't wait until you develop COVID to do something. So before you get sick, just make sure that you know how to stay in touch with others by phone or email. You may need to ask for help from friends, family, neighbors, and your community, and as well as your healthcare professionals. Also determine who can care for you if your caregivers get sick. Contact your healthcare provider to ask about extra medications to have on hand during this outbreak. Some people have the ability to obtain up to 90 days of medication, so that's highly encouraged during this period of time. If for some reason you cannot get extra medication, consider using mail-in orders for medications if your insurance allows that. Call the Epilepsy Foundation 24/7 helpline if you are having trouble getting your medicines or need financial help. The phone number for that is 1-800-332-1000. Be sure to have over-the-counter medications, for example, Tylenol, ibuprofen, and other medications that will help keep you healthy. Also medical supplies, tissues, etc. Most people will be able to recover from COVID at home without having to go into the hospital. You should also have enough household items and groceries on hand so that you will be prepared to stay home. Consider ways of getting medications and food brought to you to your home by a family member or other commercial networks. Make sure that you have an up-to-date seizure action plan. That's probably one of the most important things for you. If you don't have a seizure action plan, call your healthcare professional and make sure that that you get a seizure action plan. And if you have one, make sure that it's up to date. Next slide, please. So anyway, we wanted to show you the phone number in case you want to write it down regarding the difficulty in getting medications. Please call the 24/7 helpline from the Epilepsy Foundation. They're extremely helpful and always available to help you out if you need it. Next slide, please. So what do I do if I develop COVID? Okay, so the first and most important thing is stay home. Most people with COVID-19 will have a very mild illness and can recover easily at home without medical care. Do not leave your home except to get medical care, and try not to visit public areas. Take care of yourself, get rest, stay hydrated, take care of obtaining over-the-counter medicines, stay in touch with your doctors, call before you get medical care. Don't suddenly show up in the office for care because that could affect other patients that are in the waiting room. As much as possible, try to stay in a specific room in your home and away from other people. Also stay away from pets because they can also get COVID-19. Also, please try to use a separate bathroom if at all possible. If you need to be around other people or animals, make sure that you wear a cloth on your face. Make sure that you wash your hands thoroughly. Make sure that if you touch any surfaces, to make sure that those are clean after you. Make sure you can cover your coughs and sneezes, clean your hands very often, avoid sharing personal household items, and clean all high-touch surfaces on a daily basis. Next slide, please. All right, so we want you to follow healthy habits. If you develop COVID, making sure you're drinking and eating well, as normal as possible, get a good amounts of sleep, take your over-the-counter medications. As you may remember, initially there was a concern raised about ibuprofen that could make COVID-19 more severe, but the data does not support that. So make sure you have acetaminophen and ibuprofen at home. Most of the cold medications will be fine. You want to avoid medications that had pseudoephedrine in it, if at all possible, because this can affect the seizures in some patients with epilepsy. And also you reach out to your healthcare provider if you have questions. If you're vomiting or have diarrhea and are able to keep your medications down, make sure you call your healthcare provider and ask them for directions on what to do. Next slide, please. So what do I do if I develop COVID? It's specifically going into the talk for today, which are epilepsy. What do I do if the seizures increase? So I think the first thing I need to tell is don't go to the emergency room unless it is a true emergency. Many times you can be treated at home for this. Call your provider first. Don't just show up at the office without an appointment, because you can put the other patients that are waiting in the waiting room at risk of an infection. Many providers are offering virtual visits. They're called telehealth. Either they can do it by phone or computer. These are just as useful as an in-person visit, so make sure that you take advantage of that. Talk to your doctor or the nurse about a seizure action plan. If you already have one, update that one. If needed, your provider may recommend an adjustment in your seizure medication, or they may recommend rescue medications. Someone will be talking about rescue medications, I think, tomorrow, so you make sure that you attend that lecture. There are now medications that are intranasal, and so I think it's important for us to have that on hand. If you've already been prescribed a rescue medication, talk to your pharmacist or to make sure that you get an emergency supply of medication. And again, if you're having problems, please call the Epilepsy Foundation helpline. So some of the medications can be given sublingually, orally, intranasally, or rectally. So make sure that depending on your preference, that you discuss that with your healthcare provider. So if your seizures are lasting longer than normal, or you have increased seizure frequency and you're not able to control those at home, please call 911 or seek care in an emergency room. Next slide, please. So again, if you have seizures and you have possibly COVID, you should go to the emergency room with episodes of seizures that are lasting more than 5 minutes and no home rescue medication is available. If you have a seizure that continues for an additional 5 minutes after a rescue medication has been given, seizures that are occurring back to back without allowing a person to recover in between them, a seizure emergency that can be treated safely at home, and a seizure where someone hits their head very hard on the ground. Those are good suggestions in order to go into an emergency room. Next slide, please. So talking a little bit about mental health, I know that all of us are pretty stressed out because we're at home and not able to do a lot, but thank goodness some of the restrictions are going to and will be lifted this week, which is great news. We know that you have fears, worries about your own health, worried about your loved ones as well. This may cause changes in your sleep, eating patterns, difficulty sleeping or concentrating, worsening of chronic health problems, worsening of mental health conditions. Some people increase their alcohol intake during this period of time, or smoking more, or using drugs during this period of time. Some people react very differently to stressful situations, so we want to make sure that we go over a few things regarding your mental health. Next slide, please. So what you should do is take breaks from watching, reading, and listening to news stories. I know that these stories of COVID have been on the news nonstop for the past 2 months. So we want you to, take breaks from watching and reading or listening to stories. Take care of your body, take deep breaths, stretch, meditate if that's what you like to do. Try to eat healthy during this period of time, well-balanced meals, exercise regularly, and take your kids with you to exercise as well. Get plenty of sleep and try to avoid alcohol and drugs. Obviously that can make things even worse for you. Make time to unwind. Just, take a few minutes of the day just to have your own Zen time and unwind. Try to do some other activities to enjoy, connect with others. Again, if you're feeling down for any reason and you need to talk to someone, again, please reach out to the Epilepsy Foundation helpline. Next slide, please. So other things that you can do, stay connected with families and loved ones. That will help lower your stress and their stress as well. That will also help with this feeling of social isolation. Let older adults and people with disabilities know it is common for people to feel distressed during a crisis like this, but remind them that asking for and accepting help is a sign of strength. Call your healthcare provider, as they can always help you with referrals to anyone who shows a lot of severe stress or expresses a desire to hurt themselves or herself or someone else. Next slide, please. So in summary, most common symptoms of COVID-19 are fever, difficulty breathing, cough, sore throat, nausea, vomiting, loss of taste or smell. Seek emergency medical care immediately if you have trouble breathing, persistent pain or pressure in your chest, knee confusion, inability to wake or stay awake, bluish lips or fingernails, increase or and uncontrolled seizures. The risk of worsening seizures with COVID-19 appears to be low, so I just want to hone out into the message tonight. Again, the risk of worsening seizures seems to be low with this condition. Persons with fever, they may notice a little bit of increase in seizure frequency, and again, make sure that you have emergency medications at home. Always reach out to your healthcare provider. If you have additional questions, please reach out to the Epilepsy Foundation 24/7 helpline. And again, the phone number is there. Okay, so any questions?
Okay, thank you, Dr. Hernandez, for a really informative presentation. So we have about 10 minutes now for, or a little over 10 minutes for questions. So let everyone start to type those in. And let me see if we have any. One question that someone had asked actually on one of our Call and Connect calls was about masks, having to wear a mask for extended amounts of time. Is it possible that that would reduce your O2 levels enough that it could actually provoke a seizure or increase susceptibility to seizure if you had to wear a mask for extended periods of time?
So the masks are all breathable masks that are available currently, including the N95 that a lot of people keep talking about. Those are the most restrictive masks that we currently have, where 95 just stands with the amount of little droplets that could potentially come into you. So there's really no masks out there that will cause you to have increased CO2. But again, this could be something that you can discuss with your doctor if you have some sort of COPD or other chronic lung disease that could be affected by using a mask on a chronic basis. But again, most of these masks are breathable, and including the most restrictive one of all is a breathable mask.
Okay, it's good to know. So have any of your patients had COVID-19 yet?
So none of my patients have had COVID-19, which is interesting. I'm in Grand Rapids on the west side of the state, and we've had much less issues with COVID compared to the east side of the state. So we haven't had patients, at least that I've known about, that have contracted COVID-19.
Okay, good news. So how reliable are hospital tests via nasal swabs for COVID? Namely, if they test as negative, how confident can we be that indeed we are negative and that the test is not wrong?
Yeah, the confidence is extremely high. I think the number that I read is over 97% that is accurate. course, nothing is 100%, and it all depends on how far into your disease you're into. You might be asymptomatic or have no symptoms and go and get tested and be negative or positive, depending on whether you're a carrier of this virus, which many people in the population could be carrying this virus without even knowing it. But the PCR testing that is done through the nasal pharyngeal swab is extremely, extremely sensitive.
Okay, great. With the stay-at-home ordinances, one participant's daughter has increased the use of a tablet. Could that be increasing seizures, and presumably through photosensitivity?
It's possible. I think the most important thing that if they're going to be using a tablet, make sure that it's a well-lit room, that you give them frequent breaks from the tablet. So I usually recommend my patients to use a tablet for 30 minutes and take 15-minute breaks of using the tablet. But again, make sure that they're not in the dark room in their rooms watching their tablets, because that, especially with patients with epilepsy, because that could be a source of trigger.
Right, and also certainly if the tablet is being used to stave off bedtime, which I can certainly speak to from my kids. Sometimes that can happen. So, all right, if someone has been diagnosed with coronavirus in the past, does it give them any immunity against COVID-19?
So that's still an unknown. They believe that the answer is yes, knowing that as I showed you on the first slide, the coronavirus families, 90% of us adults can find antibodies against coronavirus. So it is possible that once you have coronavirus, you've been immunized from it, but we still don't have an answer about this specific virus.
Okay. So another person was very grateful for the presentation and happy to hear that COVID-19 doesn't necessarily increase the risk of seizures. But they did ask, if a person has COVID-19 and has a seizure, should they go to an emergency department?
If this is a first-time seizure, yes, they should probably seek care, because there are some patients that have been reported to have COVID-19, the virus itself, going to their brain and cause something we call encephalitis. So it is very possible that you've never had a history of epilepsy or seizures, and suddenly you develop a seizure during a COVID infection. It is possible that they may have the encephalitis due to this coronavirus.
Okay. And another person asked if COVID could increase the risk of stroke.
So the answer to that depends on your underlying medical history. So there are some patients that have heart disease and lung disease and other conditions that you're more at risk of developing COVID and worsening symptoms that could evolve into a stroke.
Okay, I think you addressed this, but another person asked, can COVID-19 increase the symptoms of epilepsy in a patient? So we talked about seizures. I'm wondering if they're referring to any other symptoms of epilepsy.
No, I mean, other than, for some patients that have an underlying history of inability to keep food in their mouth, or they get frequent pneumonias from aspiration, those patients their symptoms may be a little bit worse during COVID. But if you have epilepsy alone does not increase your symptoms or worsen your symptoms because you have a history of epilepsy.
Okay. Another person asked, what are the emergency medicines to have on hand? As you mentioned, I believe the national office is doing something on rescue medications and seizure response planning. We also have a Learn and Share conference call on Wednesday at noon on rescue medications for epilepsy. So I think we can talk more about that. But again, basically rescue medications are designed to stop seizures and be administered by lay people in a community setting. You can just very briefly talk about the different ones that might be that
Sure.
people might want
I
to
think
talk
it's
through?
always important for you to talk to your healthcare provider about will be the best rescue medication for you, but there are certainly multiple of them. I'm assuming that on Wednesday they're going to be talking about the newer ones, which are the intranasal midazolam and the intranasal diazepam.
Yeah.
Um, and so those two have just been recently approved, but there are other rescue medications that are given rectally, like Diastat, which is rectal diazepam. There's also medications that you can put in your mouth and dissolves in your mouth. So I think all of those are options. I think I would suggest that you discuss that with your healthcare provider. I think they're the best source of information regarding what will be your best rescue medication.
Okay, great. Another person asked, my child has fires. Should I consider him more at risk for developing the inflammatory condition that some children have had?
So the answer to that is no. Patients with a history of fires, they're at risk of developing COVID like you and me. No major risk of developing it. Could they develop a more severe case of it because of their history of fires? Certainly. We know that patients with fires, if they get any type of fever, their seizures typically get worse. So it is possible that their seizures may be increased, but not necessarily the other one, or not necessarily going into status epilepticus either.
Okay. If you were a smoker, are you at more risk of getting complications of COVID? That's a good question.
Yeah, it's a good question. Again, it depends on if you have any other lung conditions that could make this make your symptoms worse. But otherwise, smoking has not been associated with worsening symptoms.
Okay. Another person asked, and again, I think we kind of addressed this, but maybe just review it again. If a person has a history of epilepsy and has a seizure during a COVID-19 infection, should they go to the ER with a seizure during this infection?
Yeah, so if you're a known patient with epilepsy, and again, the most important thing here is don't wait until you had COVID to develop a plan of action. Make sure that you already have rescue medications at home in order to be able to treat that at home, so you don't have to go into the emergency room. But if you have an COVID, you have an emergency medication, give the emergency medication. Call your doctor's office. If the seizure doesn't stop after 5 minutes after giving the rescue medication, then you should take the patient into the emergency room for care.
Okay. We have a few more minutes for questions, so I'll allow people to think for a couple more minutes. But while people are thinking, have you heard from the national office at all whether there have been any shortages of anti-seizure medications during COVID, or any difficulty accessing those medications?
No, so my last meeting with the national office was a few weeks ago, and we have not heard of any medication shortage. We haven't heard of any emergency medication shortage either. So there haven't been any issues as far as we know. Okay. And the national office is always in contact with different pharmacies, including Walgreens, CVS Pharmacy, and the bigger retail pharmacies, to make sure that they are always carrying emergency medicines and also the chronic anti-seizure medicines.
Okay. Well, it looks like we don't have any more questions, so I think we'll go ahead and wrap up the Q&A session. And thank you so much, Dr. Hernandez, for a very timely and important presentation. And if people have further questions, please feel free to type those in the chat box, and we can perhaps answer those later.